Hey guys, Woodruff here. So we are getting through stroke long-term management, the things that we do to help these patients with their deficits. Another deficit that a patient can have is they can have loss of sensation because the brain is also in charge of sensation. So they can have paresthesias or numbness and tingling on their affected side. And so we're going to do things to help with that. And then also what's called agnosia. I talked about agnosia a little bit earlier, and this is where it would be like where there's objects that the patient is, um, should be familiar with that they're not. And this could be simple things like you could hold up a cell phone and be like, "What's this?" And they can't think of the word for it. They may also have difficulty recognizing familiar people in their lives and things like that. And so you can kind of remember they do not knows what is going on. Let's see. Come on. So what can I do? I'm going to be kind of in charge of their weak or paralyzed side, assess for, hygiene, trauma, positioning, because they may not be able to feel it. If they can't feel it, they're not going to be knowing when there's an issue with it. I'm going to do mobility devices to maintain normal anatomical position and support it. So especially if they have a flaccid or like a side that has hemiplegia, I want to support it and try to maintain a lot of that musculoskeletal stuff we talked about before. We also talked about turning every 2 hours. If someone doesn't have a feeling, they could have this like very flaccid, not moving one side. So we really want to turn them side to side. And remember, on that flaccid side or that, if they have hemiplegia or they're we call the affected side. Affected side, by the way, is the one that's like weak or not moving. What we want to do with that side is, remember, we only want to turn them on that side for 30 minutes. We can turn them on their strong side for 2 hours, but what do you call it? On that weak side, we only want to turn them for 30 minutes. I'm going to be in charge of their pressure points, and this picture has, kind of circles of what some of the pressure points are in a wheelchair and stuff too. But just always monitoring those closely and padding as needed. As for the agnosia, regular reminders and reorientation and having familiar objects in view can also help this patient just to make sure that we're keeping them safe. All right. So a nurse is caring for a client who has decreased mobility and has been mostly bedbound since having their stroke. What complications related to immobility is this client at risk for, and what interventions can we do? So, first and foremost, skin breakdown. So, skin breakdown, they're at risk for that because they're not moving as much. And like we talked about with the turning, making sure to pad their skin, making sure to provide cream and stuff like that. And we put those Mepalexes now on their butts to, prevent that extra pressure, and then regular assessments. We also talked about they're more at risk for atelectasis and pneumonia. So taking deep breaths, getting mobile, getting moving, incentive spirometer, they're higher risk for DVT, so getting moving, assessing regularly for a blood clot, doing the DVT prophylaxis can help. And then there's also constipation, which we already talked about, where they can more fluids, more fiber, more movement. And if that doesn't work, then we can try some medications. So that's just a few, but I'm sure there's more here, but I think it's a good start. All right. I think we've only have 2 videos left. You're getting close. And so am I. Yay! We're almost there.